Hello and welcome to Kaweah Health's monthly webinar with our CEO, Gary Herbst. We're glad you joined us today on March 27th. We're going to be discussing several things. Several questions have come in today. We're going to be talking about our February finances. We're going to talk about whether or not those FEMA funds have come in. We're going to talk about the Crisis Stabilization Unit and OBGYN. But before we talk about any of that, our CEO has been on vacation for a couple of weeks. So did you do something fun?
I did.
Okay.
So my wife and I and our two good friends from Fresno, we first flew to Nashville and spent 3 nights in Nashville, Tennessee, went to the Grand Ole Opry, went to the Country Music Hall of Fame, stayed downtown. If you've ever been to Nashville, which I'd never been before, what a fun city. Staying Broadway and just so much to see, such incredible artists there, the music. And I'm a country fan, so, but it's not just country music, it's just, every kind you could imagine. So, and so we were there till Friday, then we drove to Memphis, went to Graceland, saw the home of Elvis and walked through the museum and everything. And then the next day we got on a riverboat out of Memphis and sailed down the muddy Mississippi all the way to New Orleans. Spent about a week on that and stopped at various points along the river route and learned a lot about the Civil War and got to see where it took place. Saw a lot of southern mansions and plantations and got to take in some of the culinary delights of the South. And so, yeah, we had a good time.
Yeah, was a beautiful cruise?
I'd never been on a riverboat before. I've been on ocean cruises, which I'd have to say I probably prefer. It's a tiny boat. There were only 150 people on the boat, and so you definitely get to know people, and you're not going to believe. So, Kathy Milanazio, is that how you say her last name? So Kathy Milanazio, longtime employee at Kaweah, very involved in our trauma program in the emergency department. She and I are on the same cruise. Can you believe that? She just retired from Kaweah about 6 months ago, and we're sitting in the hotel lobby getting ready to take the bus to the port, and we're looking at each other. Gary? Kathy? I mean, yeah. And her husband, Ed, what a great guy.
Yeah,
And so
that is
we
funny.
got to spend time with them. But no,
That's
had a
great.
good time.
Well, good. And are you rested?
You know, I was very rested on the cruise, but it doesn't take long when you work at Kaweah to get back into the groove. So it's been a busy week. I've already had a couple board meetings still late in the evening. And so, yeah, now they're just fond memories.
Yeah.
But
Well, we're glad you're back and we're glad you had some time off. So, all right. So let's talk finances.
yeah, so I did get to come back to some good news. In fact, again, we had a board meeting last night, just a monthly board meeting, and Melinda Tupper, our Chief Financial Officer, gave a full report on the results of February. So the 8th month of the fiscal year. So we're now, that's 2/3 through the fiscal year, only 4 months left. And she was talking about budget planning. Packets were just sent out to all of our leaders about already putting together their budgets for next year, which it seems like we just finished. But we had positive news to report. So for the month of February, we actually ended the month in the black in terms of our operating margin, which is taking all of our operating revenue from all sources, the vast majority of which comes from providing patient care. So from Medicare, Medi-Cal, Anthem Blue Cross, all the commercial payers, that's 99% of our revenue. But we do generate revenue from the Lifestyle Center and the cafeteria and the gift shop, other sources. So less all of our expenses, labor and supplies and physician fees and utilities and everything like that. So when that dust all settles, we had a $277,000 positive operating margin on about $73 million in total operating revenue. And so while our total operating revenue actually exceeded our budget by about 1.6 million, our total operating expenses also exceeded budget. So even though we ended up with a positive operating margin, it was still less than what we had budgeted for the month. And the higher than expected operating expenses really continues to be almost entirely related to labor, salaries and wages, contract labor, employee benefits. We are definitely using a lot more traveler nurses than we had anticipated in the budget. I think we had budgeted that we would probably average over the course of the year that we'd use about 60 traveler nurses, significantly less than, the more than 200, almost 300 travelers that we're using at the height of COVID. But we still definitely have a need for travelers, but we were thinking that we'd only need about 60. We have 60 alone just in the emergency department right now. So staffing continues to be a challenge, although Diane Cox, our Chief Human Resources Officer, reported last night that we only have 145 open nursing positions right now. It's still a lot, but it is lower than we've seen in a long time. So we're running over budget in contract staffing. Also, you may recall that we had only budgeted to make 50% of our match to our 401k plan. But when we learned about the FEMA applications being approved, the board took action, I think it was in December, to instruct us to fund 100% of the match. And so because we only budgeted 50% of the match, but we're now accruing 100% of the match, that's causing us to run over budget in employee benefits. So now, 8 months into the fiscal year, we still have an operating loss of 16.1 million. So our total operating revenues are less than our total operating expenses by 16.1 million, which is about $1 million higher than what we had budgeted. So we actually did budget for an operating loss for the year. By the time we end the fiscal year on June 30th, our budget was projecting a $12 million operating loss for the year. Now that doesn't include any FEMA funds, so because that's considered to be non-operating revenue. But when we look at just our operating revenue, which is really what the banks and the credit agencies really focus on, because of the significant pay increases that we had to put in place this year just to remain competitive, to comply with Senate Bill 525, we knew that it was going to be a tough year. We knew that we were going to have an operating loss. And so we're pretty much, even, a $16 million loss is obviously it's a big loss and it's not sustainable long term, but it's very close to what we were budgeting. We definitely expect, like we saw in February, that we're going to see profitability over the remainder of the fiscal year. And so that's how we'll go from having a $16 million loss at the end of February to maybe a $12 million loss by the end of June, maybe even better than that. So that's where we are. But if we count FEMA, which I know we're going to talk about in a second, and we count our investment earnings, so interest income on our cash and investments, that is also considered a non-operating revenue source. So when you add what we're expecting to receive in FEMA by the end of the year and those investment earnings, we actually have a positive bottom line, so what I call net income, of 42.6 million through February. So that's an outstanding position to be in. We have recorded a receivable from the federal government for FEMA. So we've recognized that non-operating revenue in that 40-something million dollar bottom line, but we have not yet received it. So you probably want to know, where do we stand with FEMA, right? Next question. So earlier this month, at the beginning of March, we did actually receive a payment from FEMA of $546,000. We actually have had multiple applications, I think 6 or 7 different requests or applications submitted to FEMA to reimburse us for various COVID-related expenses. So this $546,000 that we got in March was to reimburse us for the cost of performing diagnostic testing on patients to see if they had COVID or not. So that was definitely a pandemic-related expense that wouldn't have been incurred had it not been for COVID, which was formally declared by President Biden as a pandemic and an emergency that would qualify for FEMA funding. So that's what that was for. We still have the final 2 applications, the biggies, one for 33.2 million and one for 14.5 million. So those both relate to reimbursement for contract labor, extra shift bonuses, and overtime that we paid to largely our clinical staff, again, during the pandemic to help us care for those COVID patients. So those are the 2 applications I've talked to you earlier throughout the year that they've been formally approved by FEMA. They're now in the final stage with Cal OES, which is the California Office of Emergency Services. So they are actively finalizing their review. It's unbelievable the amount of validation that we're having to go through. So Melinda also shared with the board last night, we're still submitting invoices. We're still showing them where this cost directly ties to a patient that was positive for COVID and so forth. But we still have, we still have every reason to believe that they're going to be final approved like all these others have been. We've never had any of the claims denied or rejected. And so we firmly believe that it's just weeks away from receiving these funds.
Because they already were reviewed and
They-
then sent up
they
and
have
then
been-
approved and now sent back and now they're being
This is
reviewed.
probably the 4th or 5th stage. I mean, it's unbelievable. There are so many agencies and divisions within agencies that have all conducted their own independent reviews. And we thought that we were told that once it gets to Cal OES, well, then it's just a matter of being paid. But no, that's not what happened. We then got assigned a Cal OES agent who is doing a complete full validation himself. But again, we've been told by everybody this is kind of a formality, although it still feels like we're having to do a tremendous amount of justification and validation. But once we've got to this point with every other application, they've been fully paid. So, but obviously these are big amounts. There's a little unrest at FEMA right now. So until we have the check in hand, we're gonna remain nervous.
So more to come. We'll continue to talk about
Yes.
this. So we also talked last month, and the question was asked, do we have any updates on the Medicare, Medi-Cal reimbursement changes that the government was threatening to make, or they were hinting around that they might be making those changes moving forward?
Yeah, so let me talk about the present and then the future. So, the present, as far as Medicare reimbursement, on October 1st, we got our normal annual, what they call the Market Basket Index update, which is 1 to 2% increases in Medicare reimbursement rates. So that went into effect on October 1st, 2024. With respect to Medi-Cal, there are 2 things that happened that are expected to increase Medi-Cal funding. The first was the passage of Proposition 35 in November that made permanent the Managed Care Organization tax, the MCO tax, where managed care organizations like Anthem Blue Cross and Blue Shield and so forth, they pay a tax on their revenues to the state that is going to use that tax to increase Medi-Cal reimbursement rates to doctors and hospitals and other healthcare providers. So that was supposed to go into effect on January 1, 25, but the Department of Healthcare Services is still writing the detailed regulations of how that tax is going to be converted to a higher Medi-Cal reimbursement payment, again, to doctors and hospitals. So we've not seen that increase yet. The other, you heard me talk about, this is a program for district hospitals called the District Hospital Directed Payment Program. That actually went into effect on January 1, 2023. But on January 1, 2025, the state, through federal funding, added an additional $800 million, took it from $200 million a year to $800 million a year. So they added $600 million to the annual pool that will flow to us 33 district hospitals. So that added amount, that $600 million, that did go into effect on 1/1/25. So we are accruing a higher level of reimbursement, but we won't actually receive those additional payments for 2 years from now. There's a 2-year lag between the date the service is provided to a Medi-Cal patient and the date you actually receive the payment.
Why?
Because they, number one, it's measured on an annual basis. So they have to wait till all of calendar year 2025 is completed and all the claims that will continue to come in January and February, March of 2026. So they have to allow for all that. Then there's this audit and validation that will occur over the ensuing months until finally we get to 1/1/27 and everything's now been audited and validated and everything, kind of a lot like FEMA. And then we'll finally receive payment for those services. And that will be done through what they call an intergovernmental transfer, where COEA will have to send money to the state. We're expecting that this additional 600 million of it will mean about 40 million, maybe 44 million increase in Medi-Cal funding for COEA alone. But we're going to have to send money to the state, who then will draw down on federal matching funds and then send that 44 million to us in a lump sum payment. So we'll just have to be patient. But at least we get to start recording that higher reimbursement, which is helping our bottom line, helping our debt service coverage ratio, one of our bond covenants. So it's still important.
So Prop 35, though, it was approved and passed by the voters,
Yes.
and it was supposed to go into effect 1/1/25.
Well, it will go into
Will it be
effect.
prorated or will
But
it-
yeah, it'll be retroactive back to
Retroactive.
1/1/25. But the detail regulations, I think this might have caught the state by surprise that it passed in the election, because Governor Newsom was very opposed to it, because it no longer allows the governor and the legislature to use that tax to prop up the general fund and the budget. And that's how he has been using it. And so the voters basically overrode him and said, no, you're going to use it to, as you first intended, to increase Medi-Cal reimbursement rates to doctors and hospitals. So, so that, happened on November 5th, that approval. And so now it's taking months for the state to actually now write the detailed regulations about how each and every doctor is going to get paid, how hospitals are going to get paid, how much is going to go to inpatient and outpatient and so forth. So, so again, being patient, but we'll get a retroactive, payment for that. Now, what you kind of led off with is, okay, the House of Representatives passed a budget framework, so not really a budget. and they charged the Department of Energy and Commerce, who's responsible for the Medicare and Medicaid program, they told them, you need to find $880 billion in savings out of your budget. Well, a huge amount of that department's budget is Medicaid. And so that department has already put together a whole laundry list of cuts that they would propose making to the Medicaid program to help them achieve that $880 billion cut. And so shortly after that budget framework was passed, and that budget framework did not make any mention of cuts to Medicaid at all. And then President Trump went on record on television stating that he does not intend to touch Medicare, Medicaid, Social Security, and he's vowed not to touch them, which then you scratch your head and say, well, then how does the Department of Energy and Commerce possibly save $880 billion? Impossible without touching those programs. The biggest thing and the thing that we're most worried about is Medicaid, as I think I've probably shared with you in the past, is a shared program. And so every state puts up their amount for Medicaid funding, and then the federal government puts up its amount. The amount that the federal government puts up varies state by state based on the average or median income of that state. So it's based on the wealth of the state. So one of the poorest states in the nation is Mississippi, has one of the lowest median income levels, and that's what its citizens, that's the median income earned by its citizens. That's a measure of that state's poverty. So in Mississippi, the federal government puts up 78 cents for every Medicaid dollar, and the state of Mississippi puts up 22 cents. Well, in California, a very wealthy state where the average or median income is much higher, in the state of California, like the state of New York and New Jersey and so forth, our match is only 50%. So Mississippi, 78% from the feds, we only get 50%. And the reason we get 50% is that's the floor. So at a minimum, every state gets at least 50%. If you took that floor away, California would drop to 42%. And then the state would have to put out 58 cents on every dollar. It's called the FMAP, FMAP. It stands for Federal Medical Assistance Percentage. Again, varies state by state. And so there's two things that the government is looking at, the administration. There is what we call original Medi-Cal or base Medi-Cal, which is is Medicaid in the state of California. And so it's always historically been that folks living at the federal poverty level, at or below, that are citizens of that state, you can qualify for Medi-Cal. And it's that segment of the Medi-Cal population that is paid at that 50-50, 50% federal, 50% state. When the Affordable Care Act went into effect back in March of 2010, that Affordable Care Act included a provision that would expand Medicaid. It was voluntary. States could choose to participate or not. Under Governor Schwarzenegger, California was one of the first states that volunteered to participate in the expanded Medicaid program, which now took the eligibility from 100% of the federal poverty level up to 138% of the federal poverty level. It also allowed single young men to enroll in Medi-Cal. When it used to be families, women with children primarily were in the basic Medi-Cal. And so it added about another 35% in Medi-Cal beneficiaries in the state of California. And the incentive to states that the Affordable Care Act had is if you expand, the feds will cover 90% of the costs. So not 50-50, but the feds will put up 90 cents for every dollar, and the state only has to put up 10 cents. So we had millions and millions of new Medi-Cal enrollees jumped into that. So the feds, not only are they looking to drop the 50% on regular Medi-Cal to down to 45%, or get rid of the floor altogether, which would drop it down to 42%. They're also talking about doing the same for the expanded population and dropping it from 90% down to 50 or 45, or letting that go to 42 as well. If those two things were to happen, it would be billions of dollars of lost revenue to California. We estimate that it would cost Cahuilla about $60 million a year, which would be devastating. You imagine that to date we have a $16 million operating loss. To lose $60 million of our funding, it will be devastating for California hospitals, who will be forced to close many new services, or many services. I can't even begin to fathom how it would change the landscape of California hospitals. And there's no hospital that would be immune from it. It would be, district hospitals, public hospitals, 501c3 hospitals like St. Agnes and Adventist nonprofits, Valley Children's Hospital, particularly hospitals with a heavy Medi-Cal population would be those that are most impacted. So I've met with Jim Costa's office. I've met with Vince Fong's office. Let them know exactly how this would affect Cahuilla. But we're just waiting with bated breath right now. I can't even begin to, we're definitely thinking about what we would do in the event that this was to happen. But I don't even know what to talk about yet, frankly. So more to come.
And when are they supposed to be making those decisions?
Well, they're working on them right now. They passed a continuing resolution through both the House and the Senate, and President Trump signed it, that will fund the government through the end of the federal fiscal year, which ends on September 30th. And so everything is funded now with this continuing resolution, but that doesn't mean that they can't replace it with a budget. So I believe that the House and the Senate are still working on their versions of the budget. It now is in the committee. The House passed the framework, which kind of gave an outline, and now it goes to every single one of the government departments that now are responsible for various elements of the federal government, like the Department of Energy and Commerce. So now each of them are developing their budget proposals, and then they'll get brought together, and there'll be the reconciliation process. And at the same time, the Senate is working on their form of the budget, and then eventually the House and the Senate bring their versions together, and they try to reconcile and come up with a consensus that eventually gets acted on, and then it goes to the president. So I can't remember how long it's been since we actually had a budget, a federal budget that went fully through that process and got signed by the president. This government continues to run on perpetual continuing resolutions.
It's very interesting. So lots to think about.
Lots. Yes.
Yeah, and so speaking of that, OBGYN care, we've been talking about this for several months when we recognized it as a crisis several months ago. But I was fortunate to go to see Ryan Gates and Rita Barron speak at a town hall at Cafe 210 a couple of weeks ago. And Well, it was very informative, and of course, Quia is doing, they're really working hard. There was still an air of impending doom in the room because everything we've known about OBGYN care and your doctor delivering your baby, that whole model seems to be changing. And so there were a couple of younger women in the room that have high risk pregnancies. And they were asking about, well, what happens here and what happens there? And Rita and Ryan were being very honest about, that it's going to take longer to get in to see an OBGYN. Normally, a woman who is pregnant, they want to see him at that 6 to 8 week mark. And then they also talked about even post delivery care and what that means for postpartum depression and anxiety in new mothers. So it was a very good event. And like I said, Kuia just, we rolled out all of our cards, and it was really great to see how hard we're working, and we're partnering with Altura and other organizations. But there is just a fear and anxiety that it's going to be interesting to see how that plays out. So Ryan mentioned at that meeting that he had been meeting, I think that week he said that week alone, he had been talking to 8 different OBGYNs,
Right.
and that they were making offers to these doctors to try to get them to come into our community. And so the question was asked, hey, where are we at with all of those offers that have been put out there?
Yeah, it's a very fluid, dynamic situation that we have right now, and probably every day, there's something new that's occurred. I greatly appreciate. I've heard nothing but fantastic things about Ryan and Rita and the job they did at that town hall. And you're right, Quia has taken a significant lead in helping address and resolve what is still absolutely a crisis. I think there's more encouraging news that I'll share with you, but I would still say we're far from being out of the woods, and it's still very tenuous and fragile, and it doesn't take much, to kind of knock it off its foundation. So Ryan did shared with me that we have interviewed 7 OBGYN physicians since the beginning of January, since the beginning of the new year. We have 3 that are very interested in coming to this community, and we're well along with them in the recruitment process, and they will be shortly coming on site to do site reviews and just learn more about our community and our hospital, and so we're increasingly optimistic. We are definitely leading the way in terms of the competitiveness of our offers. We are pushing it, as far as we can and still stay within fair market value constraints. But we're hearing from all the candidates that the offers that we're making are highly attractive. So that's good. So it's not going to be money that prevents them from wanting to come here. And so we'll be setting up those on-site visits really in probably the next week. So in addition to that, you've heard me talk about our work with creating a robust, comprehensive, what we call an OB hospitalist program at Quia. We currently have what I'll call a laborist program. And that laborist program is comprised of our local obstetricians, those that work at Altura, like Dr. Banks, Dr. Vincente, and those that work in our own rural health clinics, Dr. Sabagal, Dr. Holly Quinn, Dr. Kadimi, Dr. Runhel. And so every day we have a laborist that's either physically in the hospital or is on call that is there to deliver a baby when a mom shows up ready to deliver that does not have an established relationship with an obstetrician, with a community obstetrician, either through a clinic or an independent obstetrician. We call those unassigned deliveries. Right now, or historically, there's only been about 50 of those a year. But it's very narrow in that sense that this group only delivers those unassigned patients. And we know we need much more than that. And so, with the blessing of our Department of Obstetrics, we sent out a request for proposal across the country to formal OB hospitalist groups that are out there that do this, that staff hospitals' OB programs, but in a much more comprehensive way. And so we finalized our decision to work with a company based out of South Carolina called OB Hospitalist Group. Clever. But they staff about 200 hospitals across the nation. And when I say much more comprehensive, it's like not only do they deliver those unassigned babies, but they also will deliver any baby that, say, a community obstetrician doesn't want to come in at 2 o'clock in the morning or doesn't want to work weekends. We have like Dr. Holly Quinn, a young mom herself that wants to spend time with her family and maybe would be comfortable having a dedicated in-house OB hospitalist group physician deliver her mom's babies at 2 in the morning or on the weekend. So I think it's going to be a great recruiting tool to have this service available. And OB Hospice Group has found over time that many community physicians, while it might start out just delivering unassigned babies, it quickly grows to also delivering community babies as well. Plus, for the first time, on our second floor of the East Tower is where our labor and delivery triage unit is, which is essentially an emergency department for moms, expectant moms. Doesn't mean they're ready to deliver, but maybe they've got a complication, they've got bleeding, they've got something that's going on, and they would normally come to the emergency department on the ground floor, but we have an emergency department on the second floor that specializes in labor and delivery and pregnant moms. And so this OB hospice group will also fully staff that triage unit, which we don't have physician staffing right now. In addition, they will respond to the downstairs ED, they'll respond to mother baby, to the nursery, wherever they're needed. And so we are in the final stages of negotiating a contract with the OB Hospice Group. They have actually, in fact, they're coming on site today. Ryan Gates and I will actually be meeting with them this evening at 6 p.m. So we'll be meeting with the OB Hospice Group leaders and inviting all of our community obstetricians to be there as well. To see what interest they might have in participating in the OB Hospice Group program, and how can we partner together. So getting very close to that. There's actually a physician, Dr. Cano, C-A-N-O. He lives in Reedley. He's practiced at Couia. He actually came here, it might have been earlier this week or last week, and went up on the labor and delivery unit, and everybody's, oh, Dr. Cano, how are you? How have you been? Where have you been? So he knew a lot of the physicians, knew a lot of the nurses. He is the, the OB Hospitalist Group, the South Carolina group. He's their medical director at Cottage Hospital in Santa Barbara. So Cottage Hospital contracts with the OB Hospitalist Group. When he learned that we were looking to put them here as well, he said, I would love to come back to the Valley. He still lives in Reedley. And so he has already received approval from the OB Hospitalist Group to become the area director here at Couia. And so we're excited about that possibility. Now that doesn't address, the outpatient, the prenatal care, the post-delivery care and everything. And so this really is the most immediate when mom shows up at Couia, needing to deliver or having a problem that needs to, some emergency attention. So we will continue to aggressively recruit So these three candidates that are kind of coming through the final stages of the recruitment process, that's our answer to that. We're also working very hard to keep all of our existing obstetricians in our community. We've had some leave. Dr. Bosman going to Tennessee. Dr. Boken, Lorianne Boken going to Porterville. We can't afford to lose our current community obstetricians to other communities. So we're continuing to work very hard to keep them here as well. And if that means, they want to leave their current group and come join us, again, making them very attractive offers to stay in the community. So we're pulling out all the stops. But it is, again, I would still unfortunately be characterizing still as a crisis. It's getting a little bit better. There's good news on the horizon, but we've got to execute it all.
Okay. So staying on the focus of children, we talked a few years ago about the crisis stabilization unit. It's probably been about two years ago, 3 years ago. And so I was asked if we had any updates on that.
Yeah, so we're still have been pedal to the metal. We have been targeting an opening date in August, September. However, Kevin Morrison, our director of facilities, who's overseeing that project, did share with me that this week those leaders that are very involved in this project and will have responsibility for its ongoing operations, they want to make some changes to the plans and the design. And so Kevin's working with them to evaluate, do we really need to make those? Are those critical? Because most of the time when we have change orders, that results in a delay. And so we don't want a delay. We need to open it as soon as possible. So if those changes are determined that they need to be made, then we need to process them as quickly as possible and incorporate them into the project. So right now, still looking at August, September as the opening date.
Okay. How many kids do we currently?
On a monthly basis.
Excellent question, hot off the press.
Oh, good.
Yeah.
I was hoping.
Apparently not something we readily, retain or track. But thank you to the ED staff who were able to provide this information to me. So over the last 6 months, October 1st to kind of where we are today, we have seen 207 pediatric patients with a primary diagnosis of a mental health condition, that they came to the emergency department not with a medical condition, but with a mental health condition. So 207 over that 6-month period. Of those 207, 43 of them required an admission to a mental health facility. We do, in our near future here, we will be adding a 22-bed child and adolescent inpatient wing to our mental health hospital over on Acres. You may recall that we received a pretty sizable grant from the state to help us construct that. So we're in the planning design stages of that right now. But currently, there are no child and adolescent inpatient facilities in our immediate service area. So these 43 had to be transferred out of our community to an inpatient unit. So those 207, so think over a year, more than 400 that came to our emergency department, that certainly in the mental health area is really probably more geared towards adult, and that's what really motivated us to develop the Child and Adolescent Crisis Stabilization Unit, which is kind of an emergency department for children that are suffering a mental health crisis. So those patients would have not gone to the regular ED. They would have gone to that CSU. So we definitely need it. We definitely need to get it open as quickly as possible.
Right. So the 160, so take out the 43 that needed to have a facility, the 160 that would, because that's just a 23-hour, the crisis stabilization unit is
Yes.
just a 23-hour
Yes.
facility. And then if they have
Which-
to be placed, then hopefully when our mental health hospital is completed for our pediatric wing, we'll be able to see most of those
Yes,
there, yeah.
exactly.
Wow, okay. All right, another child question. Does Kauai Health System provide gender-affirming care to minors?
No,
And
we do not.
you do, okay, that's not even something we do in this area or just not in our hospital? Do you know that?
We don't as a health system. That doesn't mean in the outpatient setting. I don't know if there are physicians in our community that provide that care. It's a possibility. I'm not aware of it. But as far as Kauai, no, we don't provide that.
Okay. So now this is a very interesting question. Why don't we call our nursing school the Kauai Health Nursing School? Because a community member reached out to me and said they had run into somebody, they had an employee that wanted to get into the nursing school. She's an employee here at Kauai.
Right.
But he was trying to help her find the information, and they were typing in Kauai Health Nursing and all of these things. And so I said, oh, no, it's called Unitech. Unitech. And so I was thinking, I don't know.
Well, I mean, technically, it's not our nursing program.
Okay.
Unitech is an independent, institution, educational institution, generally based on the West Coast. I think they have 8 physical facilities on the West Coast. But it's Unitech. It's owned by Unitech. It's a completely separate company. So I don't think they will change their name to Kauai Health. But I think we've kind of branded it here. The Kauai Health Nursing University or School powered by Unitech.
Affiliation.
Yeah, I've heard that terminology. Maybe it's not as pronounced as it needs to be, but yeah. Well, maybe we'll talk to Jamie Morales, see if
Yeah.
there's some
So I
way that
sent
we
them-
can connect it a little bit
Yeah.
more formally. But technically, it's not our program.
Yeah.
Yeah.
Okay. All right. Who knows? Who knows what the future holds,
Well,
We are a teaching
we were
hospital.
talking about it last night at the board meeting. So in January of 2026, we will graduate our first cohort of 25 nurses that will all graduate with bachelor's degrees in nursing. And they will join the Kauai ranks as a full-blown registered nurse. And they made a 3-year commitment after they graduate, and we hope they fall in love with Kauai and want to spend the rest of their career here. But it's not just Unitech. I mean, COS has done a phenomenal, Jana Schengel and Brent or Brett,
Right.
Brent?
Right?
Sorry.
The big tall guy, 6 foot
Brent
9 or
Calvin,
10.
yes,
Brent
Brent
Calvin,
Calvin.
yes. So they've done a phenomenal job expanding their nursing programs and really supporting Kauai. And then San Joaquin Valley College and Porterville City College and Fresno State. And I think Jamie Morales had indicated that when all of those schools start fully graduating their nursing students, that we will see more than 400 nursing students enter this market. So
That's-
very excited
Yeah,
about that.
that is great.
Yes.
Okay, so we've answered all of the questions. We do want to announce there's a kickoff for the foundation's new
Yeah,
campaigns
so
or anything.
tonight at 5 o'clock in the Sequoia Wing lobby, we will be formally kicking off our campaign called Tiny Feet, Big Steps. And through that campaign, we hope to raise approximately $3 million to make some significant renovations and modernization of some key areas of the hospital. Talking about children, we have a 12-bed pediatric unit that is staffed by pediatricians that are part of Valley Children's Hospital. And so they're all located in the east wing or the east expansion of the Mineral King Wing. which opened in the early 90s. I think it was 1992 or 93 that opened. So that's where that pediatric unit is located. And it sits right next to an 11-bed unit that we've historically called the Broderick Pavilion, named after longtime nurse Kathy Broderick. And that is kind of our short stay surgical unit. So where patients that maybe have had a knee replacement or a hip replacement or some elective surgery that requires a pretty short stay after that to make a full recovery. It could be a day, 2, maybe 3 days. That's where those patients go, into that 11-bed unit. So we're going to completely refurbish and renovate and modernize that 11-bed unit and the 12-bed pediatric unit. We also are going to take 4 of those pediatric rooms and remodel them in a way that they will be called flex rooms. And as a flex room, it can be used either as one of those short stay surgical recovery units, or it can be used as a pediatric room. And so during the busy winter months where we see RSV and other respiratory conditions, that's when we generally see our pediatric volumes at the highest. Then we could use all 12 of those beds for pediatric care. But in the non-winter months, when the pediatric census generally drops down to 4 to 6 patients, but we still have a lot of adult surgical patients, we can flex with the state's approval to use those 4 beds for adult. So increasing the Broderick Pavilion from 11 up to 15 beds. So these hybrid rooms are becoming more and more popular as hospitals are building new facilities, new rooms. They're building the rooms now in a way that not only could they take care of patients with medical surgical needs, but they can go all the way up to an ICU level as well. That they just have that ability to adapt to what the demands are at the moment.
That's great. And then we're opening a new clinic. And so we have our ribbon cutting ceremony next week.
Yes, so our second rural health clinic in Woodlake, we're very excited about that. I know Dr. Medina and Dr. Alash, our primary care physicians that practice in Woodlake, are very excited to see that new clinic opening up. So yeah, next week.
So the 3rd, Thursday,
April
the 3rd, at 5:30, we will be doing the ribbon cutting ceremony. We'll be giving tours. Evidently, it is beautiful.
It is.
I haven't quite seen it yet. You've seen it?
I have not.
Okay,
I've
so
seen
the plans
photos
and-
along the
yes,
way, but
yes.
I've not seen it in its current
Yeah,
form.
and so that's going to be ribbon cutting, be a really great event. If you are in Woodlake and want to hop over, come and see us on the 3rd.
Yep.
All right, Gary, I think that's about it.
All
Do
right.
you have
Well,
anything else?
thank you, Deborah. Thank you again to all of our community engagement members. And once again, thank you for continuing. Are we coming up on we just passed our 5-year
We just passed
anniversary?
our 5th year. Wow. 5 years.
Unbelievable.
You guys look great after 5 years.
Yeah. And if you still want us here, we want to be here. So unless we hear otherwise, we're going to continue to come to you every month, and appreciate all the great questions that you always submit to us. And again, I didn't say at the beginning, but we certainly invite you to chat in, during the broadcast. If a question comes to mind or you have a follow-up question on something we talked about, love to address those as well. So hope you're all enjoying this beautiful, beautiful spring day. It looks like the weekend is going to be absolutely gorgeous. So yeah, thank you again, and we'll see you next month.